Welcome back to PedsCrit. I'm Zach Hodges, a pediatric intensivist from the University of Texas Southwestern in Dallas.
And I'm Alice Shanklin, a pediatric intensivist at Cohen Children's Hospital in New York.
And we are so excited to be sitting down and speaking with Dr. Jaime Jump on withdrawal of life-sustaining therapy. Dr. Jump, please introduce yourself. Tell us who you are and what you do.
Hi, I'm Jaime Jump. I am currently a critical care and palliative care physician at Texas Children's Hospital. I'm really excited to be here today.
Is it true that you're also the palliative care program PD?
This is true. Yes. This is my first year. I was APD for 2 years. This is my first year as PD.
Oh, nice. Well, good luck to everyone matching. So you're, of course, dual trained in pediatric palliative and critical care. Can you tell us why this career path was best for you? Like, why did you pick it? How is your training as a palliative care physician helping your critical care practice?
Yeah, it actually spurred during med school. I was always interested in kind of hospice and end of life. But when I was in my critical care fellowship, I think we are always put in situations, high risk, high stakes situations, end of life situations, and we're not trained to do it. We're still not trained to do it. And communication is something that can be just like a learned skill. And I wanted to get more comfortable in those situations for my patients, but also found a lot of gratification in taking care of and holding patients at end of life. And I feel like sometimes you kind of know if you can do that work long term. And so when I did my palliative care fellowship, I just feel like, when I come back full circle and I talk to people, my palliative care training's made me a better intensivist and vice versa. My intensive care training has made me a better palliative care doctor. And I think, just kind of when I talk to people now, it's like communication can be learned. It can be taught. It can be, better, and really love to foster even some of our critical care fellows now and pursuing more outside the box communication training.
I'm jealous of the dual trained palliative care docs, intensivists. I have a wonderful opportunity to work with them locally here. And something that I didn't realize early on as a fellow is that I thought the hard things were going to be like getting that art line that no one can get and like getting that central line and crashing a patient. But like the hardest procedure we do is talk to families and patients and work them through these worst days of their lives. I think that the individuals that get the opportunity to train in both palliative care and critical care just have exceptional skills there. So kudos to you for the great work.
No, thank you.
As we move to today's topic, any conflicts of interest to disclose?
None.
All right. So say we're at the bedside. We have this, school-age child, maybe 9 or 10 years old, who unfortunately has relapsed leukemia, lymphoma, has been intubated, and has respiratory failure in the ICU. It's clear that the oncologic prognosis is poor. And in addition, the child is developing multi-organ dysfunction, is intubated, has ARDS, has refractory pain and agitation requiring a propofol infusion, and even requires some neuromuscular blockade for bad respiratory failure. It becomes clear to the family, it becomes clear to all the teams taking care of this patient that this child is at the end of life. And now we're starting to talk about more what withdrawal of life-sustaining therapy might look like for this patient, for this family in this clinical scenario. So as we get to that today in our topic, will you please define what is withdrawal of life-sustaining therapy, otherwise known as WOLST?
Yeah, I think, we used to think about it as just technology, right? And I think it's all the things. I think you have to think about, I think one of the things we do in palliative care really well is getting to know the family's goals and values. And those values can even be surrounding what's important at end of life. We often don't ask those things. And so, knowing what their goals and values are will kind of drive how we can talk to families about what we continue and what we take away, as we're approaching end of life. And I think those are the things we just have to think about. It's not just removing the ventilator. It's not just taking them off ECMO. It's not just taking them off CRRT. It's also, are we going to do labs? Are we going to give blood transfusions if they're not helping? Are we going to continue the antibiotics? And so I think it's really helpful to not just think of it as the broad, we're going to remove these things and this child's likely to die in hours to days, whatever our prognosis might be, but also thinking about what things we're going to do, and also reframing our minds to there's maybe nothing more that we can medically do to cure the patient, but there's so much we can do to actually care for the patient, and not forgetting to use that language when we're talking to families.
When I first heard the term WOLST, withdrawal of life-sustaining therapy, my initial impression was it's more of a passive thing, like we're withdrawing care, right? We're going to stop doing things. But as I've got more exposed to it and worked with families through situations like this, it's a very active therapy, right? Like there's a few things in my work that I feel like require as much attention as the last few moments of a child's life, and especially during these times of when we're withdrawing life-sustaining therapy. I want to give you the opportunity to emphasize how this is an active process and not necessarily a passive one where we're taking things away.
Yeah, I think it uses all parts of our critical care brain because you give us that case that we're talking about, and it's what's the underlying pathology. If a kid has relapse refractory, disease, especially cancer, but we think the respiratory therapy is likely to contribute highly to when we remove the breathing tube, that we likely think that they will ultimately die as a result of moving that technology. It's using our critical care brain. So what kind of respiratory failure? Is it hypoxemic? Do they get hypercapnic when you turn down the rate? Because those types of things can really help you, right? We know that when you have high CO2, you're pretty comfy, right? We've seen the kids that come in CO2 greater than, 60, 70, 80, and they're pretty much, sedated, for lack of a better term. And so using those things in your critical care brain, what can I do that I'm not just having to load them with a bunch of meds, but how can I use the end of life physiology, the physiology that unfortunately is beating us in the critical care realm? How can I use it to make this patient more comfortable?
Oh, absolutely. Zach has really given us a case here with all of the players, right? This patient is paralyzed. They are on propofol. They are likely on broad spectrum antibiotics. They may or may not even be still getting chemo. And as we shift our goals from prolonging their life to keeping them as comfortable and cared for as possible at the end of life, my first question is, this patient is paralyzed. How are we distinguishing this from like a physician-assisted suicide euthanasia? And then my second question is, I'd really be interested in hearing your thought process as you sort of work through their current plan of care and think about, okay, we're taking the breathing tube out. What are we doing with the paralytic, the sedation, things like that?
Yeah, I think that's a really great question. And I think we should always know that paralytic at end of life, we want to take it off, right? And so I think we always have to balance, we can't assess symptoms at end of life if you have neuromuscular blockade on board. And so, I think in the highest level situations, if the neuromuscular blockade is on because, the patient decompensates without it, they're not, syncing with the ventilator, there's lots going on. I think it's a risk-benefit conversation that becomes really bigger than this talk about, what does it mean when I turn off the neuromuscular blockade? And how can I prep everything else to be ready and hopefully discontinue that, and in 15, 20 minutes, we see some signs of them doing something, their diaphragm moving on the ventilator, them wiggling something, just making sure that we can assess the symptoms. And I think that's the biggest thing. I always say to people, it's really not ethically okay for someone to die under neuromuscular blockade, and unless it's like an extenuating circumstance where you turn it off and all of a sudden, the kid decompensates, which we won't know sometimes. Sometimes we're like, hey, I'm really worried that this is going to happen. But I think you still have to try to do it, because I think there's just risk of just not knowing what's going on underneath that. We don't even really do a great job. We try, right? We use vital signs. We use Train of 4. We try to get to know, where are we in terms of, the use of paralytic. But I think we just really can't know what we're treating if we have a paralytic on board.
Yeah, would need to be extenuating, like this patient will be in excruciating pain, whether it's from the high vent settings or something else going on with them, not paralyzed, right?
Yeah, and I think some of the conversations I've had is a kid who's on the oscillator, right? And so they're neuromuscularly blocked. And I think that's the question of, when you turn off the paralytic and you're on an oscillator, kind of what happens? Do they decompensate right away? And they might. But I still think it's okay. I think you can try to get ahead of the symptoms and just prepare the family that that's the case. But we ultimately really frown upon that. And that's one of the top things I talk about in my talk, the paralytic must come off. And if we're having trouble, then we can kind of troubleshoot what are the other things that we have to think of about the symptoms. And sorry, I'm going to go back because I forgot the second half of your question.
No, I really appreciate you leaning into this important detail about neuromuscular blockade, right? It's a hot topic and something we need to be really careful with. Circling back, I want to give you a chance to focus in on the other part of that question. How is withdrawal of life-sustaining therapy distinct, very different than physician-assisted suicide or euthanasia?
This is often a question we get. And I think we have to remember, when we are doing end-of-life care, it's standard care for treatment, right? So we can go into a whole other talk about lots of people say, well, isn't that palliative sedation? And no, let's give definitions. So euthanasia, right, is giving medications to end somebody's life, right? Like that's the full stop definition. You are giving medications with the intent to end somebody's life. We are never doing that in the ICU. We are giving medications with the intent to relieve suffering and to control symptoms, right? So our medications themselves, not directly correlated with end of life, even though I think oftentimes when we're the physician or the bedside nurse, right, like give that last dose of morphine because they're having respiratory distress and they feel like, oh my gosh, I gave that morphine, then the patient died, I killed them. And I think in my experience of having the honor of being at many end-of-life scenarios, I've never seen that happen. I've seen kids that are not intubated on pentobarb infusions, on Versed infusions with a native airway who have taken 36 hours to die ultimately of their underlying disease process while we're controlling symptoms. So I think it's very important to think of that. And oftentimes people say, oh, well, I'm doing palliative sedation at end of life. And no, like palliative sedation in itself is different from WOLST, is different from euthanasia, because that is a whole other discussion where we are actually using medications to relieve suffering. We've tried every avenue, right? Interventional pain. We've tried all the things. We've gotten all the people together. No matter what we do, we cannot control pain. And we are using medications to then sedate them to unconsciousness to relieve suffering, right? And it gets muddy, but that is like a different scenario. When we're doing end-of-life care and we're using our medications and we're taking technologies away, we are just using our medications to prevent suffering and control symptoms. So I think that's the big differentiation for us. It's not about ending their life, it's about controlling the symptoms and suffering.
Yeah, I want to further lean into like controlling suffering end of life. So when you have family members, when you have parents starting to identify that their child is suffering, and they're starting to think about what if we are at the end of life. And especially when you completely agree with that, when you see that this child is in the last few days of their life, how do you introduce the idea of withdrawal of life-sustaining therapy? And how do you perhaps even respond to some of those initial emotionally triggering questions that the family will ask in response to that as well?
Yeah, I think honestly, good communication throughout is so important, right? No matter who it is, even if you're just taking over, it's your first couple days on service, I think kind of taking the time to kind of lean into like, hey, I'm really worried. I'm really worried that no matter what we do medically, I'm worried Johnny's going to die. And that's hard for people to say because we're in the business of saving lives in critical care. And so when we are in a scenario where we're really worried and we have agreement from all the subspecialists, like I think we say that because I've never, in my intensive care hat, said that to a family and had them be mad at me at the end of the day if their kid survived. So I think it's like throwing those things in and kind of gleaning from the family, where are they, right? Because sometimes we think we've been clear and we haven't been clear. And I think it's clear communication. Then I think it's talking to them about, here are the things that we can do to let Johnny have the most comfortable death we could imagine. And we know that no parent wants to ever think about that. But then it's giving them the opportunity to ask you questions and for you to respond with like the best you know how to like, this is how we're going to make them as comfortable as possible. Here are the medications I'm going to use. Here are the symptoms we can watch out for. And it is hard because you're going to have some families that are like, I can't hear that right now. And I often like offer like, would it be helpful if we get to the point in the conversation, would it be helpful for me to describe what I imagine this may look like in terms of symptoms? In my teaching for end of life, I always tell parents that like our bodies physiologically are just like smart. So when we start to take away things, like I always have a blanket up until like their neck because we want to focus on their face, right? That's the most telling sign for us, right? Our vitals are going to look different. We're not going to focus on those. We're going to focus on the face. We're not going to focus on their chest. We're not going to focus on any of the things that, we get more acidotic. We're going to look terrible when we breathe. We're going to get mottled. We're going to change colors. We're going to, all the things that we might expect. And if the family's asking, I think you have to be willing to hold that. And I think you have to give yourself some grace if that's hard or you feel like you can't do it. And I think like these are the times where I often say like partnering with palliative care, right? We don't have to own the room, but sometimes having language, sometimes like, hey, can you help me think about this? Because it's such a like emotionally charged situation that I think when you're in the intensivist, there's so much going on around you. There's so many people you have to corral nursing, RT, your trainees, whoever is there, and then, making sure you feel like the family is supported. And sometimes I think like this is like a plug for palliative care where we don't have to have that relationship with the family, but we can help you think through all the steps and what should we be talking to the family about, and what are things we're worried about on the outside of the room kind of situation and logistics.
Oh, absolutely. Being able to really orchestrate that and think of everything as the palliative care team is huge. Okay. So you've given the tough headline to the family. They agree that now knowing they're in a different place, they've made the decision to withdraw life-sustaining therapy. You're in the room. I appreciate the blanket up to the neck. What other things are you giving the family for anticipatory guidance about the process? And then what other granular things are you setting up in the room?
Yeah, that's a great question. I think, in this case, right, we're worried about the underlying lung pathology, right? Like it seems like this is kind of where we're the most shaky. And so I think when we're in the room, there's lots of prep to be done for this kind of case. Also, I think one of my talks with families when we're talking about this is often before we even get started talking about meds is surrounding what fluids or feeds are we running. And I think we often don't think about this because it doesn't necessarily seem like top tier important. But I think when, we're at the end of life and our body is shutting down, we all know we're not peeing well and we're third spacing all of our fluid. And so as we start to do that, it can become uncomfortable, make you swollen. And then, oftentimes we prepare families for like, hey, their end of life breathing might sound really terrible. And people say, hey, Jaime, why is that? And it's the loss of upper airway tone, but it's also the more fluid overloaded that you are, the worse it's going to sound. And so deep suctioning does not help. So we're going to get rid of that. We are going to stop our fluids or feeds. That would be my recommendation. And I think this is always a tough situation because we know parents they want to feed their kids and that feels like, hey, I'm starving them. But just reframing of like, our bodies are shutting down. We are not hungry. Those types of things, we really have to focus on, hey, we're not starving, but this is what we're preventing. So I often talk to them about the feeds and fluids, the blanket up to the neck. We're not going to deep suction, and telling like RT in the nursing, that's not going to help. I often talk to them about color change and temperature change, right? So often, talking about hands and feet getting cold, some central warming, some change in their color, getting pale. And I think for this one too, it's saying that you don't know is really important, right? Because of all the kids that I think are going to die, they hang on for a while. And I think it's always preparing families for, I expect when I take this breathing tube out, that they may die quickly, but giving them the minutes to hours or even days or more so that they're prepared and they're like, it's so emotional. And I think that anticipatory grief that we see with our families is almost harder than when the patients die. Like they're just the anticipation of everything. And it's like this big relief. And so you don't want to get them all like, oh my gosh, it's 6 hours later. Why am I still here? And so I think talking about all those physical changes with the family is super important. Talking about monitors, right? That's a big deal. I think, we can put them on comfort mode. There's some parents that are like, I want to see the numbers. I know they don't mean anything, but I always say, I want you to be a parent first. And I want you to just focus on Johnny. And so if those monitors often take away from it. And so we can put them on comfort mode where we can see them. And I also say, we don't need to see them, right? Like we don't need to pronounce you the moment that a kid dies. And we often forget that, right? Like a kid can take their last breath. People will be crying and emotional. We don't have to go run in there. We can give space and time before we go pronounce death. And so often telling them that the monitors mean nothing to us and we want them to spend that time is really important too.
Oh, that's huge. I really appreciate his body might do different things. His skin might look a certain way. We need to just focus on his face. That's what's going to show us pain. Do not worry about the intercostal retractions, right? Like just focus on his face.
Jaime, I really like that you also included not being caught in that question with the family, how long is my child going to be alive? And I think keeping that very broad and reinforcing, we're going to be with you. We're going to be taking great care of your child, regardless if it's minutes, hours, or days. You've kind of already mentioned that we're going to see some signs of respiratory distress at the end of life. We're going to see color changes. any other symptoms that we should anticipate, preparing for this withdrawal of life-saving therapy?
Yeah, I think it's hard because, again, every case is going to be unique. So the case that you guys gave us, like, we're thinking about all the things. We're thinking about respiratory distress. We're thinking about secretions. We're thinking about pain. We're thinking about dyspnea, right? Like that feeling of like, I can't catch my breath. And so I think we have to think, from the top down when we're thinking about respiratory things, using your vent to your advantage, right? So if we go from top down, if I'm giving you like kind of a sign out, use your vent to your advantage. So you're in respiratory failure. So it's like, Jaime, what am I going to do? I'm going to turn down my rate, especially if I have hypercarbia as a piece of my puzzle here, because that's like nature's sedation, for lack of a better term. I think you turn down the rate, see where your CO2 goes, and see, if that seemingly helps with your sedation piece. And it's going to, right? You can do it as you're getting ready, 15, 20 minutes as you're getting everything ready, just to kind of get that on board. And I think we miss that all the time because we know how to reverse the problem. But when we're doing end of life things, we often forget that. And that's something that I've reminded a lot of intensivists, in my palliative care hat. And they're like, oh, that was like so smart. I didn't think about that. So use that tool. I think the second piece too for secretion. So this is always a topic that we talk about a lot. Glycopyrrolate tends to be your top choice if you're thinking about like if they have a ton of secretions. Yes, we go back and forth, right? Because you don't want somebody to have a massive plug and that be the problem. But again, if we're thinking about after we've removed breathing tube, which we'll talk about a little bit, glycopyrrolate doesn't cross the blood-brain barrier. So it's less likely to cause delirium type of symptoms, which is something we also get worried about. So you can utilize your atropine drops and things like that. Are they super helpful for the things we talked about earlier, like somebody sounding horrible when they're breathing? No. Will it kind of prevent all that pooling of secretions that's kind of the pathophysiology that you're in, where they can't handle their secretions, or it's somebody with severe neurologic injury and they have that problem at baseline? It's something to think about. But glycopyrrolate not crossing the blood-brain barrier often works to your advantage as you're trying to kind of keep your delirium to a minimum. And, for the respiratory distress, the first line therapy for dyspnea is actually opioids. And I think sometimes people forget that. They want to reach for their benzo. And so, theoretically, this patient, if they're on neuromuscular blockade, you're going to want to stop that if possible. So you have that stopped and you can assess your sedation and you're going to use what you're on. We don't use propofol very often, but if you have that on, just reminding yourself that, hey, it's not giving me any pain control. So it's like sedating this kid, but I need an opioid infusion, which they're probably already on. Another thing to consider too, if a kid is not on dexmedetomidine, get it on, because there's some studies coming out there in the literature, especially in the onco world, about dexmedetomidine will actually decrease your opioid usage over time, especially in these scenarios. And so is it going to give you a super big bang for your buck at end of life? Maybe not. But also, if you get into the situation where you're going up and up and up on drips, it might give you more use than we know. I don't think we have enough data to say, but having that on board is like something I make sure that we have. And then, having a benzo is there. Do you have to have it as an infusion? I don't think so. I think you have to kind of see where you're at in terms of your sedation. But yes, you can put an infusion on. Yes, you can have PRNs. But then you're also like thinking about your delirium component. For this case, I imagine it might be short-lived, right? Considering how sick the kid is, relapsed refractory cancer, and we're in ARDS and we're really sick. But for, other patients, it's just saying like, where are we going to be in the spectrum? How much do I think I'm going to have to escalate? And thinking about the meds we're comfortable with. We're comfortable with fentanyl. We're comfortable with Versed. We're comfortable with Precedex. We have ketamine options, but also thinking about, delirium can be escalated when we use a benzodiazepine. So thinking about those things and then thinking about what can I do for my delirium, right? And a lot of people say, well, nothing. And it's not true. Haldol is actually an amazing tool to use IV for delirium and can be used as often as like every hour, every 2 hours. We just don't frame our brain that way because we worry about QTC prolongation and we are not used to using Haldol. We're more comfortable in the Seroquel or, those types of medication classes for the kids that are long-term, sedated intubated in the unit, but thinking about how if your delirium ramps up and thinking about giving an IV is really important.
Oh, wow. The last thing we want is for our patients to be hallucinating at the end of life, right?
Yes.
Like anything you can do to get them a little more coherent is huge.
Jaime, Alice and I are just chomping at the bit to ask you all these really practical, like, how do you get this done type questions? And we're going to get there. Before we just dive into all that, I want to give you one more high level question. You mentioned opioids end of life. And as intensivist, as palliative care doctor for yourself, treating pain, agitation, end of life is an emergency. Someone who maybe hasn't been exposed to this as very much might have reservations giving sedatives and opioids at the end of life with the worry that it might hasten death. Will you just help us understand, why is it ethically permissible to give something like morphine at the end of life when it might technically make death faster?
There's a principle like of double effect that people talk about of like, we're giving the medications with the intent of relieving the symptoms. And whatever happens after that, the intent was never for the patient to die. The intent was to relieve the suffering. It's just hard to wrap our brains around, right? Like any other procedure, we wouldn't let a kid sit at bedside and say, debride a burn without sedating them. The same thing is kind of true here. We see symptoms in front of us, we're going to treat them. I also will say, as a topic for another day, like these end-of-life situations, no matter how clear they can often cause moral distress. This is different than an ethical question, right? But sometimes I think depending on your institution, if it's really stressful, if you feel a lot of that moral distress amongst teams, sometimes getting your ethics consult in the chart is really important, right? Because it really documents, hey, this is ethically permissible. The things we're feeling are just because we're people and this is a hard job and we're morally distressed about it, but it doesn't mean that it's not the best care that we can give to this patient or family. And sometimes, especially depending on where you are, big institutions, lots of people involved, it kind of helps to tamp down our level of emotion so that we can focus on the patient and the family.
Oh, absolutely. And I think we'll link the few doctrine of double effect pieces. This is the result of a Supreme Court ruling. I think it was Tim Quill versus the state of New York or something.
Yep.
That are really powerful to read. Is it okay if I get into the nitty gritty now? Because this case is really working. I have so many questions. Okay. So school-age child, relapse cancer, ARDS, paralyzed propofol, fentanyl midaz. I really appreciated the first thing you said, which was, why are they going to be uncomfortable when you take the paralytic off? Is it the high vent settings? Is it delirium? You can try and treat both of those things pretty aggressively when you're in this phase of care. So I'm going to give you some medication doses and let's talk through what we're doing. All right. We're on propofol of about 200 mics per kilo per minute, rocuronium infusion, fentanyl of 4, midaz of 0.2. And it's been like the 3 weeks of all of this. And so you're walking into that room, you're starting the process of withdrawing treatment. What are you going to do with those meds?
Yeah, this is a great question. I think we often get caught up in dosing, right? So I hear you. We're at high dosing for all these meds, right?
Yeah.
And high settings. So I think you can consider two things. Are your doses working, right? Like we're at a fentanyl of 4. Do we actually think it's working? Are we in the period where we think we have tachyphylaxis and like it's just not doing it? And so in these scenarios, if it's working, we'll go from there. If it's not working, I would suggest a class switch before we do this. So to morphine or Dilaudid, right? So that's what we would do. And I think adding your Precedex here is important, right? So it's another agent. Theoretically, will use less opioid potentially. So I think let's add Precedex on because it can't hurt anything, right? It's going to help sedate you. It's going to help with some pain control. So we put that on. And I think we just say, honestly, it's not about the doses for me because every patient's going to be different. If I have a kid that's been in the unit for 3 weeks, 4 weeks, more longer, right? Their doses are going to be different and their responsiveness to medication is going to be different, but you go up by 50 to 100% based on symptoms. And I think that's really hard for people because this is a great question because we often get asked, but like, oh, it's so crazy. And yeah, I've seen some crazy doses and I think people have wanted to go back and even like review it from an event standpoint, but it doesn't matter, right? You're using whatever the patient needs to get comfortable. And then if you're not getting benefit from the meds you're using, then it's going outside the box and thinking about things like, ketamine, PRNs, or barbiturates even, if we're getting to the point where our standard meds that we're comfortable with in the ICU are not helping the end of life situation.
Let's say for this patient, you just take some of the pressure away on the vent. You maybe flip them into ERT, just see how things are going. You observe spontaneous respirations. Things look a little bit better. Maybe the patient appears comfortable or just slightly uncomfortable. Do you think that you would maybe add some Precedex, leave all of the drips at their current rate for your palliative extubation?
In theory, we've weaned the rate, right? So hopefully, like, we're building up some hypercapnia, depending on I would assume this patient's sick enough that would probably be the case. And then I would bolus probably your benzo and your opioid prior to taking the tube out, right? So you have more med on board, you take the tube out, and then you can kind of see and escalate your infusions. That's the beauty of being in the ICU sometimes, is that we have these infusions where we can bolus off pumps. And so we don't have a ton of things, but sometimes having more meds is better. If we're really worried about this kiddo, and I would be, because we're on high settings, we're on lots of meds, it's having some of those PRM meds that you're like, I probably won't use it, but there's no harm in having some doses of ketamine by the bedside. There's no harm in maybe me having a dose of pentobarb if things get really tough. And, using your propofol. But again, where we are, like, is it really going to be beneficial? It's really hard to know. So I think, like, just being really thoughtful about having the tools in your toolkit just in case, right? That's the prep. That's like what I tell intensivists all the time. They're like, well, we just, stop these machines and we turn it off. No, like, use your ICU brain. Like, what is the next med I'm going to use if something doesn't go my way or how I'm hoping? And like, having all the tools there, you'll be happy you had them, even if you don't use them.
Oh, yeah. Like, if your opioid is like water for sedation because of the tachyphylaxis, it probably also won't treat end-of-life dyspnea.
Yes.
Right? Like,
yes.
So it seems like really what we're focusing in on here is how to practically do rapid ventilator weaning at the end of life in preparation for a palliative or end-of-life extubation. And I have a couple of follow-up questions there, but before we get there, I just want to just kind of circle back and please let me know if my mental model here is correct or incorrect. So it seems like when you're preparing a child for withdrawal of life-sustaining therapy, you have things that you want to do a day ahead of time, maybe 12 hours ahead of time, and then you have the like in-the-moment things that you're doing. So perhaps like the day ahead of time, you really want to get your hand on, like, what's the fluid balance? Are we making sure they're not fluid overloaded? Perhaps even secretion management in preparation for that. Sedation.
Like, stop the feeds, stop the deep suctioning 24 hours prior, ideally, type of thing.
I think if we're in that conversation piece, it could be, I think it's important to say, like, hey, this is not going to cause imminent death, but we want to prevent more harm. So yes, like, thinking about it, the sooner the better. I would love that. We thought about it 12 or 24 hours ahead of time.
I think the pitfall I'm trying to emphasize here is that this is not something you do all at one time. You don't decide at 10 o'clock in the morning, we're going to do a WOLST at 11 a.m., 1 hour later. Oh yeah, turn off the fluids, whatever. I feel like it's not wonderful to do all of these things at one time. You certainly can get it done, but I think preparation is really helpful here. And then kind of as we're getting kind of closer and closer, maybe in the room at the time of WOLST, I want you to talk us a bit more on how you practically do rapid ventilator weaning. What I'm imagining you do is you wean the rate and you look for respiratory distress, you treat respiratory distress, and you wean the ventilator more. Please tell us more how you do this, some potential things for you to emphasize. What do you do with FiO2? How quickly do you wean the rate? And then how do you know when you've pushed the child too quickly or maybe not fast enough?
Yeah, it's a great question. I think, honestly, it's a best judgment kind of scenario. I wish there was more literature. I've wanted to write a little bit about compassionate extubation. I've been in the room and I've weaned like the rate by 2, and then I wait a couple minutes and then I keep weaning it. And I think PEEP also, like, if you're on a PEEP of 14, man, we are pulling the rug out from under you when we take that tube out. And so sometimes if we're on a high PEEP like that, I'll do the same thing and just chip away. And yes, you can treat. Most of the time I focus on the rate first, because in theory, if we're going to become hypercarbic, that helps with my sedation. And so when I've done it, I've worked on the rate first, get them down. If we have an end tidal that's correlating with a gas, I'll kind of trend it and, just see what their sedation level will be, treat the symptoms, like you said. And then I think it's the same thing for the PEEP, right? Like, trying to get somewhere in the 10 range, 10 or 8 without kind of them completely decompensating, but just knowing that, like, when you remove the tube, there's kind of just less of a physiologic process of, the body adjusting. And so there's no way that I would say you have to do it, but I think it's just being mindful. You're going in, you're taking 15, 20 minutes of your time as everybody else is getting things prepped in, nursing and RT and all those things, and just monitoring the patient and like, okay, I think, our CO2 is a little bit higher. They seem a little bit more comfortable. We're going to just wean these things as they go. Again, we can run into scenarios where those little changes make big clinical changes. And I think that's just like a discussion with the family at the time that you're doing it of like, hey, we're really having trouble doing this. I'm going to get my meds on board and we're going to take the tube out, and we're going to go from there, especially if you have parents. And I think this is another thing that could be a whole other talk, but we often have distress over what parents want to do at end of life. So depending on what their values are, do they want to hold them? Do they want to be in the room? Can they not be in the hospital? Right. And we pass a lot of judgment, not intentionally, but we can be very, I think, biased against parents who physically can't be there for whatever reason, like mentally, how they're going to grieve later. And so knowing what's important, right? If you have a family that really wants to hold them as they die, like maybe if you start to wean and they decompensate, it's like, okay, we're going to just take the tube out and let them be in your arms, or we're going to take the tube out while they're in your arms, getting creative about those things. That's why it's so case by case. Like we can write the best algorithms for these things, but there's so many nuances to it. And I think a lot of places where we have to check our own opinions and biases and at the door and try to focus on, what is the task here? And the task is to get the kid, our patient to die as comfortably as possible, surrounded by whatever that family deems appropriate, which is hard.
It seems like one of the better cases, as you're doing rapid ventilator weaning, the CO2 is increasing and the child is becoming a bit more somnolent from the elevated CO2. You ensure that the agitation and discomfort is treated appropriately, and then you extubate the patient. The scenarios that I find the hardest is when children have intact respiratory drive and that carbon dioxide level does not increase. And you start seeing quite a bit of tachypnea and worker breathing there. Any pearls to offer about how to navigate that situation? And I bring this up because I feel like the breathing tube enables bigger tidal volumes and a better minute ventilation for patients. So I find that it's sometimes you can help the buildup of CO2 by removing the breathing tube, but you incur some risk of seeing more distress.
Yeah. And I think that's just kind of where the blanket theory comes in. You're going to look as a provider. You want to see, is their face uncomfortable? And I think you still go by that principle. I think it's really hard because in theory, we all think that, somebody's body who's working really hard to an intensivist is like, we got to help and we got to do something. And you are doing something. You have meds if you think there's dyspnea, but you're probably not going to make that go away. And so that's why I often say, put the blanket on, focus on people's face. You don't have to treat everything that you're seeing. And that is just, it's very hard, But I think if I've had parents where if you cover them and they're focused on their face, they start focusing on the face too. And so it's drawing your attention away from the things that we are trained to draw attention to and really focusing on the patient's face, on the global, what you get from the room. Because if you cover somebody and their face is calm, but they're working really hard, that's just, hey, like, I'm acidotic, or hey, I'm hypoxemic, or I've completely collapsed one side of my lung. But like, that doesn't matter anymore. In reality, like the pathophysiology of it doesn't matter. It's how do we keep you comfortable? So I think that's another like exercise. And as we grow as intensivists, like removing some of what makes us innately anxious and focusing on one thing.
I want to back up to maybe this is the day prior. You've had the discussion. You're planning on removing therapy the following morning. What other teams should we make sure that we touch base with?
So what are the values, right? Like, is a chaplain going to be important? What are their religious beliefs? Do they have people or things they want to come in? I think that's always a big ask, right? I want a priest. I want whatever they want. And I think is important. Asking if there's like important family members too. And this can go along with like child life and social work, just making sure that they have the people, or if there's people that they want to come see, can we get them there in an expedited fashion? Sometimes we can't, sometimes we can. Often, I think we get social work involved in child life for memory making. If you have that ability, I think it can be, for some families, they're going to say no, thank you. But for some, it can be really meaningful. We're lucky enough at Texas Children's, we also can get our art therapists and our music therapists involved. And so we can do a lot of really cool things. So depending on what your institution has available, just kind of like, I think bringing everybody in and letting the parents it's overwhelming, but warning them, hey, these are the people we're going to ask to come by. And some parents will just know, like, hey, I don't need that, or they're not going to know what they need until they start talking to people. And they might not even know what they need, after their child's died. I think it's talking to all those teams, making sure you kind of get prepared. And I think it's also, like we talked about, like logistically with your team, who's going to be here tomorrow? Can I prep the respiratory therapist? Can I prep the trainees on my team? Can I prep myself? Can I prep the fellow who's on if they don't have experience in doing it? Can I empower them to kind of be part of it? And so I think it's thinking about like holding those people like, hey, this is hard. Tomorrow's going to be a hard day. Does anybody have questions about that? So like kind of all those things. So you all feel like you're one team when it's actively happening. I think it's important.
No, that's excellent. And I can tell that you're thinking about how can I prepare the entire team, always being mindful of your trainees. And just to add to these incredible comments you've already shared, if the child has a primary specialist, letting them know. If they've had a surgeon in the past, letting them know. And then, of course, your local organ procurement agency, because we have protocols in place to make sure that everyone is appropriately getting screened, even if you know that this child is not going to be eligible for that service.
Yeah, I think it's important. Like some of the things we've implemented at Texas Children's, we have an end of life navigator that's accessible. And I think that's helpful. It goes with the nursing team step by step, like who do they have to call, like including the OPO, including the medical examiner, for example. And it kind of goes through the whole checklist and all the papers that need to be signed, all the logistical things. And I think that has become a really helpful tool because often if we have nurses or any kind of staff who haven't done end of life before, there's often a lot of questions that do pop up. And, kind of even preparing yourself for the things you've never thought you'd be asked. Like families are going to ask, like, what happens after they die? And every institution is like, most of them, the parents can bathe the child and dress them and stay with them for pretty much as long as they want in some reasonable time frame. And I think it's just, the parents are always curious, like, where do they go? Right? Like saying that they go to the morgue is important. Knowing, for us, for example, they don't have to pick a funeral home before they leave. They can go to the morgue, they can take a deep breath, and like our social work can follow up with them. Like certain institutional things I think are really important, like to have just as a fund of knowledge, because globally you've like gained a lot of trust and a bond with this family, even if you just met them. And so just being able to sometimes like say, hey, I'm going to have somebody else come talk to you about that, but this is what's going to happen. So it's not like you have to constantly find somebody else to garner that information if you happen to be in the room.
Oh, that's huge. There's nothing worse than calling the medical examiner too late and then the family's like held hostage for another 4 hours in the lobby or something.
Yeah. And the things we have to think about are tough, right? Like even if we can remove things is tough, right? Like depending on the scenario that you're in and the one we're in about, end of life and relapse refractory cancer, there's not going to be any contraindication. But, if you have a trauma or, some, non-accidental trauma, there are implications of removing things and devices, and that can be distressful. But as long as you know beforehand, I think all of us can handle it confidently that some of the things are above our control that we have to leave in place.
I think I got one more follow-up question for just logistics of a WOLST. I think I've learned that simplifying the room can be really helpful. So if a child is on perhaps continuous renal replacement therapy, getting that out of there so we can have more room around the patient. Kids in similar situations that we've described today, respiratory failure, they're commonly on vasoactives. Will you just let us know, do you have any other tips for managing multi-organ dysfunction? We've really focused on the respiratory component today. Anything else to add there?
Yeah, I think it's just thinking, again, about your pathophysiology and are the vasoactives the last thing you're turning off, or are you using it for another purpose? And I think thinking about it's the same like the ventilator. And often even when we're on ECMO, I think WOLST gets really tricky a lot of times because we're used to doing something, but sometimes forget. So if we're on VA ECMO, for example, and say our native heart function is really not good, if we stop the ECMO and then give meds, we're not sure if they're even going to circulate or how well they're going to circulate. So it's often thinking about giving those meds before however you decide to discontinue the ECMO is done. And it's just a reminder, right? Because we're not really thinking about it that way, but it's also like, what equipment do you have on? And likely if you're on CRRT and we haven't been making urine, those kids will die without making urine in 12 to 72 hours usually, but that's usually not going to be the prime cause. So like CRRT, I think, is less of a huge lift than ECMO or, other things that we're doing. But I think those are like the biggest things to think about. It's just, what's your pathophysiology? And like, do I give meds before I stop the ECMO because I'm worried they're not going to circulate? Or, let's get everything out of the room that we can. If we have nitric on, like, can we get that off and out of the room? Like, we can have multiple technologies, multiple medications. And I also think it's thinking about your meds too. Like, can we stop drawing labs? Can we stop pretty much giving anything that's not symptom control? Because at the end of the day, it's not helping us, and it's just giving the nurse another task that's not focused on what our task at hand is. It's like, oh, the ceftriaxones do. Like, no, like, let's focus on something else. And so I think it's like de-escalating your orders the best you can. And we often forget about that just because there's so many standard orders in the PICU, changing all of that so that nurses aren't prompted to come ask you about things.
Yeah, I think like one very practical thing, like the child that's preparing for a WOLST doesn't need a 4 a.m. x-ray, right?
Correct.
Like you don't need to get the family out of the room, right? We got to be really mindful of all those things that are just standing on the chart that we do for every critically ill child. We're not going to pause the opioid infusion to give some PRN med. That's not like helping their pain and symptoms.
Mm-hmm. Getting them from a crib to a bed is also nice. The family can lie down with them.
Yeah, it's another like great thing to offer for sure. I love when we can do that.
You mentioned preparing your team and especially your residents and trainees. Is there anything you do prior to say, okay, we had this family meeting, we're doing this tomorrow morning? Anything specific you do prior with your residents to make sure they're ready?
I think it's just like allowing space for feelings and to talk about it. I think, we're so hustle and bustle and next thing. So I think just allowing that space is just enough to say, like, this is going to be really hard. Let's talk about it let's talk about it post. And if anybody needs something more than, us just debriefing about it, we have those resources. And I think it's always just, it's so hard for us because we are trained to have these horrible things happen and move on to the next thing. And so just, I think allowing space and like showing our trainees, like, we're human in a sense, like we are, but I think sometimes we kind of moving from the next thing. Often we're really good at shielding our emotions. We're really good at like holding it together. And I think it's also okay to allow yourself, like, if you're emotional, as long as you're not upset more than the family's upset, I think it's allowable. And I think like that is so important. It shows your vulnerability to trainees. Like, I've had kids die after awful codes and, I'm teary-eyed like when I'm pronouncing them, but like, I think it shows the vulnerability to my team, right? To everybody that's worked with me is like, that was so hard. We tried so hard and here we are. And like, at the end of the day, I'm a little wrecked by that, right? Like, I don't just go home and say another day and, that was a hard day relatively. And so I think just holding space, allowing them space to debrief. It's hard to do because we're busy, but really important.
I think you bring up a really important point. We all three work at academic institutions, and I feel like the low-hanging fruit here is we want to, give our trainees an opportunity to, decompress after a WOLST, and we want to hear their concerns. We want to explain their situation, what they're feeling, rationalize it, help explain that it's normal. But I think the harder ask is, how do we model for them how to deal with the emotionally charged situation of taking care of a child at the end of life, and how can we display that we're actually processing this and we're human and we're not just compartmentalizing. It's much easier to just put on the attending hat and just, this is just what I do each day at work. But it's much harder and it's much more helpful, I think, personally, as the doc and as the educator, to show like, this bothers me and this is how I deal with this and this is how I process this and this is how I hope sets me up for a much longer career in pediatric critical care. I mean, it's not easy, and I do not claim to do this perfectly at all.
Oh, yeah. I usually try and tell the residents that I, in my attending career, have time to just like be sad and let this process when I'm not on service next week, right? And residents don't have that. They're like at clinic, they're up, they're down, they're back in Staten Island. It's like a whole thing. And so, yeah, no, that's really hard.
Yeah, and I think it's great. I think we have to be a little bit more vulnerable at times, right? I think our field is not a vulnerable field. And I think us learning to be that way with our trainees, show that things affect us. Even talking about our own self-care is teaching them, right? Like we're all not perfect, but maybe we do something that would be helpful for them that they never thought about. Or they might come home and just be like, all right, like Dr. Hodges like was really affected by that. And like, it's okay that it bothers me. I think you normalize that just by saying out loud, like, this is a really hard thing for me to do. Even if you do it with poise and like it doesn't affect you, I think it's also important just to verbalize it.
I wanted to emphasize and clarify something. You mentioned, Jaime, that you're never sadder than the family, right? And I think by that, you mean that you're not letting your emotions get the best of you where anyone in the room feels the need to console you. And it works the exact same way with trainees. Like you're not displaying emotion that makes people feel it's their burden to take care of you. And that's, I wanted to emphasize, that's certainly not what I was advocating for.
No.
You want to display emotion appropriately, display the human side of things, but also in a very active way, show what a mature response to that looks like and how do you process that and how do you prepare yourself to take care of the next really sick patient.
Yeah, exactly. You don't want the family consoling you, but if there's tears and then you need to go take a little walk around the unit before you can come back around and deal with other things, like I think it just shows like you're a normal human. We've all been at the bedside for hours or more trying to resuscitate a kid that ultimately maybe doesn't live. And I think that's hard. It's like, hey, I've done everything I'm trained to do and physiology beat me. And I think that's defeating in itself and also just as a human. So I think it's so important. And some of us don't emote and that's okay. I've had deaths where like there's nothing there, but I can still be kind and like not because of the situation, just maybe my mood that day or however I'm processing it. And then there's been other times where I have the ability to emote. And I think just normalizing that too, that like my response to every death is not the same. And that doesn't mean it's good or bad. It's not like I care more about the kid where there's tears and I don't care when there's not tears. There's just, depends on your day, what's going on in your life, like all the things.
Yeah, oh, absolutely. Now I want to talk about something that is definitely different, like culturally at every institution, but I think we all do it. What does the structured debrief look like for you? How do you like to like formally debrief after?
Yeah, that's a great question. Like our PICU has they have one that they do like in a hot debrief kind of session. I think, we also have like now a nursing driven debrief where we check in on each other logistically about communication. We don't talk about the medicine, but could have anything gone better kind of things. I think a lot of times, like our ICU has a structure for that. I think on the palliative care side, also offer like cold debriefs, like later on, if people are still struggling, it was a high emotion case to get everybody in the room and just let people have feelings about it and not talk about the medicine. So I think every institution is a little bit different in how they create space for that and what structured debrief they have. I think, there's different ones in every different unit, across Texas Children's, the PICU has one versus like NICU does something different. So I think it's just variable, but I think if it works and your institution buys into it, do it because that's the best advice I can give. So at least you're doing something.
Jaime, this has been incredible. WOLST is something that I kind of approached with lots of trepidation as a trainee. And as I've moved into my early career as an attending, I really see these cases and these opportunities as ways to be incredibly impactful for families, for children at the end of life. And I identify with it as being a core part of my job. As we kind of move to the last couple of questions for our conversation today, what are perhaps some common mistakes or pitfalls that you'd like to emphasize that we can look out for next time we're in a situation like this?
I don't necessarily think there's any mistakes. I think it's just kind of taking that pause and taking it all in. I think oftentimes these feel so emotional and so rushed that we don't think about all the things we talked about today. We don't think about the pathophysiology. We don't think how can our technology actually help somebody have a more comfortable death rather than prolonging life, which is what we're just so trained to do. I also think it's just, using your resources. So if you haven't done it in a while, or it's really complicated. Like the case you gave today is complicated. We've been on meds. We have lots of things going on. Use somebody else's brain. It could be another intensivist. It could be your palliative care team. Like, am I thinking through these things the right way? And allowing yourself space for your own processing, as you kind of head into it. I think those are like the things we miss the little details, not because we're bad doctors, or it's just like, we're just almost rushing to do it, right? Like we might miss something like the monitor and turning it on comfort mode, because like we're just so focused on everything else that it's like, oh crap, like I really don't want that beeping, but I didn't think about that. So it's kind of taking, that's where, I can also share like our WOLST template. Like that's where it comes in, that you're thinking about all the things. It gives you kind of a template to think about all the things. And then you can take a step back and do ultimately. So I think those are the things. Prep yourself, take a step back, breathe, make sure everybody's on the same page before you kind of rush in to do anything.
Well, that's beautiful. Dr. Jaime Jubb, thank you so much for joining us today.
No, thanks for having me.